Okay, so good evening, everyone. My name is Jasmin, one of the presenters for CME today. So our topic for today is COVID-19 patients with Pallor and Jaundice. Our outline for today's CME will be case presentation and so case discussion with literature review. Okay, a little bit of background history about our patient. RT, a 47 years old female, no comorbid, no allergy. She's a para 8 housewife, non-smoker, not vaccinated. She's a small built lady, BMI about 20, was admitted in early of September last year. Okay, so she presented with 1 week history of cough with whitish sputum and associated with coryza symptom for 2 days. There's also loss of appetite and lethargy for 2 weeks. Also tinge of jaundice for 4 days, which was noticed by her daughter. Otherwise, there's no chest pain, no diarrhea, no nausea, vomiting, no abdominal pain, no pale stool, no tail color urine. And she also denied fever, no bleeding tendency, no UTI symptom. Right. Further history, there's no history of blood transfusion prior to admission, and she has been working in a farm during young age. She denies any usage of pesticide, no family history of malignancy, and there's no history of self-medication. No recent traveling history, no water sport activities, no forest visitation. And she also denies any high-risk behavior. She is a non-alcoholic and non-drug abuser. She's living in a brick house with clean water supply, and her daughter is actually an MA in working in hospital Kutas. There's no pets at home as well. So on clinical examination, she's alert, conscious, speaking in full sentences, appear tachypneic with jaundice. Otherwise, perfusion is good, CRT about less than 2 seconds. There's no finger clubbing, no tremor. Her BP is hypotensive, 76/24, with SpO2 of 93% under ventimask. DXT was 10.9. Lungs, there's generalized cause cracks. Abdomen, there's liver palpable but 1 finger breadth. Otherwise, it's soft, non-tender, no spider nevi, no vasculitis lesion or rash seen. She's moving all her 4 limbs. There's no cuff tenderness, no myalgia. PR done is empty rectum, no melena or any evidence of bleed. Okay, bedside scan done. Echo is normal. Lungs, there's B line seen, no pleural effusion. IVC is more than 50% collapsible. Abdomen, liver, and spleen grossly normal. There's no other abnormality. So this is her initial lab investigation taken on the day of admission. Her hemoglobin was low, 4.7. Otherwise, white cell and platelet was normal. She was subsequently transfused 1 pint pack cell, and her hemoglobin post-transfusion raised up to 6.4. Bilirubin was raised, about 101. Liver enzyme was normal. CK at that time is 700 plus. DXT about 10. And also her COVID PCR came back positive with CT value of 24. Other pending investigations sent, BFMP, CRP, full blood picture, iron studies, folate, B12, retic, UFME, NA, and also complement levels. And so we send G6PD, also Coombs test. So this is a chest x-ray, show there's opacities involving both lungs, right lung up to the, involving the whole lung and left lung up till the mid zone. So our provisional diagnosis at that time is COVID-19 stage 5, day 3 of illness. Points 4, she presented with respiratory symptoms of cough, and so there's lethargy. PCR also positive, and she's requiring oxygen, ventimask, and also there's chest x-ray involvement. Differential would be hemolytic anemia for investigation because she's anemic, HB level of 4, bilirubin is raised, jaundice, hepatomegaly, and there's no other evidence of ongoing blood loss. Another differential would be lepto and so malaria. So initial management, because she's hypotensive, she was given fluid resus and is responsive. Her BP came back as normotensive. Oxygen increasing to high flow mask and able to maintain with SpO2 of 98%. And also given antibiotic and also methylpred with PPI coverage. She was subsequently admitted to HDW COVID with close monitoring urine output and also general condition. Okay, this is her progress in medical ICU. In day 2 of admission, her hemoglobin level dropping by 1 gram from 6.4 become 5.5. Other investigation are normal, no coagulopathy. UFME, there's blood 2 plus and also urobilinogen 4 plus. Urgent PBF shows there's evidence of acute hemolysis, severe normochromic normocytic anemia, and marked polychromasia, nucleated RBC, and also occasional spherocytes. There's teardrop cells and also erythrocytes. No schistocytes seen. Case was then referred to hemato team, and input given was to send urine hemoglobin for infection to rule out PNH. Otherwise, on day 2 of admission, her oxygen requirement increases to high flow nasal cannula. Otherwise, her vitals at that time was stable. RP is normal. On day 2 of admission, her hemoglobin further dropped from 5.5 become 4.9. And Coombs test came back as group B positive, as both direct and indirect Coombs tests, which are strongly positive with presence of anti-IgG and also cold antibodies. This pan-agglutination is suggestive of mixed type of autoimmune hemolytic anemia, and also NTS was detected. Elution test is positive. Case was then updated to hemato team. Impression given is autoimmune hemolytic anemia. So was started on IV methylpred 200 mg/BD for 4 days. Otherwise, her vitals are stable, still requiring high flow nasal cannula, and blood CNS came back so far no growth. Okay. Another investigation, G6PD normal, ANA negative, infective screening also negative, and procalcitonin 0.4, which is not raised. Microplasma also negative. C3 was low, was 0.5. And C4 was normal. Okay. On day 4 of admission, she's having temperature of 37.8 and we took septic workup and was started on IV tazocin. She had thrombophlebitis over her right upper limb dorsal area. Otherwise, there's no other significant incident. And slowly, her blood counts were able to improve on day 8 of admission after 4 days of methylpred. There's no other bleeding tendency, and she was able to wean down to ventimas with stable vitals, and X-ray was repeated, and there's improvement compared to previous admission. This is her blood investigation summary. As you can see on admission, 12th of September, hemoglobin is 4.7. And then subsequently on 19th of September, which is day 8 of admission, her blood parameters slowly improving until 22nd of September, hemoglobin 8.5. So this is the medication given, antibiotic given total of 1 week, tazocin also augmenting, and also steroid started from dexamethasone stat dose given on day of admission, then methylpred and subsequently to prednisolone on tapering dose. Okay, this is a chest X-ray. The first picture is on admission, and the second one there's improvement compared to the on admission punya X-ray. So her outcome, throughout admission, she was only transfused once with 1 pint pack cell, which is on the day of admission at district hospital. And then she was able to transfer out iso ward on day 9 of admission, and she was subsequently discharged on day 14 with TCA review. And she was able to wean off oxygen at day 10 of admission. The highest oxygen requirement will be high flow nasal cannula. HRCT thorax came back as moderate OP lah. And currently she's doing well. on tapering prednisolone dose 0.75 mg per kg daily. This is a HRCT result. It's moderate involvement, moderate OP involvement. This one dated on 24th of September. Okay, this is her latest blood taken on early of November, which is 3rd of November. You can see the hemoglobin already in normal range, 13.8. LDH is 266. Okay, so in summary, our patient is a 47 years old, no comorbid, no allergy, G6PD negative, was confirmed diagnosis of mixed IHA with COVID-19 infection, stage 5, day 3 of illness, which is evidence-based by full blood picture, blood parameters, and also positive Coombs test. And her hemoglobin is responsive to steroid with good outcome. Here's a little bit of introduction about autoimmune hemolytic anemia.
Just comment on the case. You maybe can go back to the impression.
Next.
Just to do some correction.
This one?
It's not the day 3 of illness. Why I say so? Because your patient already symptomatic for 2 weeks. Lethargy for 2 weeks. Then coughing for about a week. So it can't be day 3. So we know it's probably around 1 to 2 weeks. I don't know whether the lethargy, initial lethargy due to anemia or due to the prodromal phase or something like that, but it's definitely longer than 3 days. Agree or not?
Yeah,
coughing for a week already. How can it be 3 days? So already feeling tired for 2 weeks. So what we can conclude is definitely around, I would say already more than a week, probably 1 to 2 weeks duration. So from this type of case, we know it's already definitely in the inflammatory phase, moving towards inflammatory phase. Maybe can go back to the serial chart. I want to see the, I mean, the X-ray already show quite a confluent changes there. She needed venti mask. So initially when she came, I suppose she came to ETD, right? So that would be stage 4. Once she went up to high flow nasal, then I think it's fair to say stage 5. So COVID-19 second week, inflammatory phase, stage 4 then becomes stage 5. CRP not too bad, only 29, like that. Not sure how much the anemia or concurrent hemolysis affected that. Yeah, but we do have quite a lot of markers of hemolysis there, the LDH and things like that. Antibiotic, let me look at your antibiotic again. Because she came in around 12, so the tazocin was started when she had thrombophlebitis. So nobody will use tazocin upfront for this type of case, because we know it's straightforward. The community cases, there's no risk factor for pseudomonas or things like that. So usually, if you ask me to check the case note, I would put it most likely to be augmentin first rather than tazocin. The date is didn't correspond to the date of admission because patient came in 12, and then Dexa was started on the 12th. You see, I would be surprised that there's no augmentin given that time. Yeah. So that's how I see this case. And then subsequently, the HRCT show organizing pneumonia. That's why the steroid was prolonged. For those of you who work in COVID before, you know the standard duration is 10 days. We only extend for clear-cut indication. So far, let's say we transition to prednisolone. Usually it is for the organizing pneumonia. I don't think Dr. Lily extend the steroid from recollection. Yeah. Okay, that's my comment. First is the COVID-19 is already second week, likely in the inflammatory phase. Even though CRP is not that high, but the X-ray and the oxygen requirement, PF ratio, everything suggests the later stage of illness. How it is related to the autoimmune hemolytic anemia, that's for the second part of the discussion, which I'll pass over to Dr. Lily's team now.
Thank you.
This is a simple introduction of IHA. Okay, so this is the classification of autoimmune hemolytic anemia. It will be warm and also cold. Usually they will classify to primary and so secondary for both. Primary usually will be idiopathic, and secondary most likely will be due to infectious, immunodeficiency, lymphoproliferative, autoimmune, and also drug exposure. So this will be showing us how we test for Coombs test. Over the left side will be direct Coombs test, and also the right side will be indirect Coombs test. So basically just adding the Coombs reagent to the samples that we have already had autoimmune antibodies. For the right side, which we need to add donor blood, and also add the Coombs reagents to make the clumping happens. And this is how a bit of the pathophysiology of the warm and also cold IHA. Both will be the warm IHA, and below will be the cold IHA, which mainly warm is due to the IgG, while below due to the C3 and also complement systems. So this is the sign and symptoms, and also the investigation of a cold IHA. That what shall we look for? So the next, I will be going to the literature review. This was a literature review done by National Center of Biotechnology. It was a study of 7 patients, which actually it consists of 7 patients that age consists around 60 to 89 years old, with at least of 1 comorbid and hypertension, CKD, DM, obesity, and mostly the onset of the symptom of IHA will be 4 to 13 days, and the HB decrease, the means of the HB decrease will be 3 grams. All patients had marked hemolysis signs with evidence of a DAT positive either for IgG or also for C3d. So actually in this literature review, that out of 7, the 5 have warm IHA, 4 has warm IHA, and 3 has cold IHA. Most of the patient they found underlying of hematological malignancies or cancers, and the time frame of this IHA symptom was correlated with the cytokine storm, which is around 4 to 14 days appeared. And within the 7 patients, 5 was given steroids and 2 was given transfusion. Only 2 patients was given rituximab for the patient number 6 and also patient number 3. Patient number 6 was given rituximab because of a failed steroids, while number 3 is because of underlying marginal zone lymphoma. And at time of case follow-up, all patient was alive and partially recovered from COVID-19. So this is a case based from National Center Biotechnology information. This like what I just said just now. The next will be by BMJ Journal. This is a case report regarding a 50-year-old man underlying of OSA, hypertension, presented with non-specific unwell symptoms of 5 days, jaundice sclera with tea-colored urine, an episode of a frank PR bleed. He claimed was previously 6 months ago had previous episodes. While he had 1 episode of diarrhea and the rhinitis coryza symptoms for 2 weeks. So his clinical examination was unremarkable, and blood pressure on admission was a bit highish. Heart rate was 110, temperature was 36 degrees Celsius. And they also noted that evidence of acute kidney injury and also raised bilirubin. Followed will be the blood investigation. The HB on day 1 is 125, while subsequently was dropped to 79 on the day 5. And yeah, the LDH was taken on the day 3 with 2,377 and in reducing trend. Okay, so actually this case was a bit of a so-called late diagnosis. He was actually treated as a acute glomerulonephritis secondary to strep infection because of urine dipsticks and AKI with high BP. So he was sent for vascularity screening and was negative. The sole treatment that was given to him was only IV drip, and he was well responded. But however, because of the HB dropping and no active bleed was seen, the case was referred to hemato team, and they suggest to work out for hemolytic anemia. This patient was subsequently discharged from hospital, and routine colonoscopy was given to him. And you can see that his HB was recovered from day 9, day 21, and also day 35. Sorry. So there's a pitfall of these patients that BMJ says that initially they do not think patient had any COVID symptoms because of his rhinitis and coryza symptom was two weeks ago, and it was just a routine screening of the COVID-19, and it came back appeared to be positive. So and the PCR is actually based on PCR test is not based on the viral culture, means like they don't have a PCT value, so they're not sure whether it's a live or dead virus. But otherwise they could not find any explanation that the trigger to the IHA. So this is the conclusion by BMJ. There may be other late manifestation of COVID-19 that becomes obvious as our experience of the disease increases. Hemolytic anemia may be a complication of COVID-19. So the last the last literature that will be presented by me will be by Journal of Hematology. This is also a case report regarding a 54-year-old African American man was presented with fever and 2-week history of a worsening of shortness of breath and cough, fatigue, and nausea. He was tested negative prior to this for 2 weeks. It was negative, and subsequently 9 days prior to the to this admission, the third PCR was positive. And 3 weeks ago, he had a tooth infection, which he took amoxicillin for 5 days. He had no history of anemia, drug allergies, or blood transfusions. On admission, his full blood count of HB was 6.7, with leukocytosis and normal platelet count. Initially, his indirect antiglobulin test was positive. LDH and total bilirubin was elevated, while heptoglobin was low. But the DAT was weakly positive for C3 and so IgG. G6PD was screened and was decreased, so it's G6PD deficiencies. While the only viral workup that they did was COVID-19, and they give a routine COVID treatment, which is the subcutaneous and also prednisolone. So actually, patient required packed cell transfusions um, from on admissions and subsequently daily transfusion. However, they noted his HB was his HB was not improving, which was given steroids, and from prednisolone they changed to dexamethasone. Then on day 9, because of the HB drop, they changed back to prednisolone again. Okay. So rituximab was not given to this patient in view of a steroid responsive, and yeah. After day 9, the HB was came up to 9.3, and his transfusion in the no need any more transfusions. So patient was able to discharge on day 14 of admission, and was continued. Prednisolone was tapered outpatient for 2 weeks with a stabilization of a HB. He had a second admission later on, but it's due to a pneumonia. Was treated with antibiotics, but however, on the second admission, that his HB was a range around 8 to 8.5 without any IHA symptoms. They also did a bone marrow biopsy that revealed mildly hypocellular marrow with no dysplasia or abnormal lymphoid cell populations. So this is the blood that the red indicates a blood transfusion, while the blue is the hemoglobin. Yeah, that is the steroids that given. So actually, in Journal of Hematology, they says that patient hemolysis actually has both immune and this is the patient that they had that both have immune and non-immune components, because that he had a positive DAT with a lack of responsive transfusion, and they think that G6PD deficiency plays a main role in this IHA. And they also to rule out antibiotic causes of the IHA of the that he took amoxicillin 3 weeks ago, but they because of the positive antibody, so they did not think that it's due to antibiotic causes, and the antibiotic was stopped for 2 weeks already. Yeah. So this conclusion from Journal of Hematology, they think that actually hemolytic anemia in COVID appears multifactorial. The exact mechanism, however, the exact mechanism still needs further evaluation. But they also think that G6PD plays a main role in this IHA. So they had studies also regarding the total case reported in the world. There's total 26 of IHA associated with COVID was reported. Both warm and cold COVID was implemented, and the time frame of the IHA was at the first 2 weeks of infection where the cytokine storm appeared. Then 5 reported cases was underlying hematological malignancies. Majority patients was treated with steroids and are steroid responsive. Only 3 patients was received with rituximab, and 3 was received with immunoglobulin. And all the patients have a good outcome, which they survive and able to discharge from hospital. Yeah. So actually, we do not have a strong evidence of how COVID induced IHA. However, there is a hypothesis going, saying that the cytokine-rich inflammatory environment causes the alteration in antigen presentation, creating the cryptic antigens, which stimulates the T lymphocytes and in turn activates the autoreactive B lymphocytes to produce the antibodies against the antigens. So that's I'll conclude my my presentation today here, and yeah, and this is the reference. Dr. Lily, anything to teach us or share with us?
Not really lah. Okay, but the thing like this lah, I think to work out the hemolytic anemias lah, yeah, like COVID, yeah, just from your literature, I see there's a few patients who have lymphoma, isn't it? Yeah, there's
Yes.
something to watch out lah for this patient as well lah, yeah, because maybe he has a occult lymphoma. She has occult lymphomas that we haven't picked up lah. Yeah, that's one for the patients lah. Second thing is like in the management of first of all, like the workup for the anemias. So of course you look at, for her is mostly anemia, isn't it? So anemia, we think about the causes. Of course, one of the possible causes is hemolysis. Hemolysis, of course, you look at the bilirubin, and bilirubin is raised, and there's indirect bilirubinemia. Yeah. I would say for a person like her, what's her age again?
47.
47, huh?
Yeah.
I mean, it's not say unlikely, but to present as a G6PD for the first time is not, especially women, is less likely lah at this age, If there's a kid, younger teenager or something, then G6PD is more lah, more likely. But there's a difference. Of course, like him, IHA is probably one of the commonest autoimmune, commonest hemolytic anemias that we encounter. So of course, if you have hemolytic anemias, you suspect because bilirubin is raised, LDH is raised, then you would do a Coombs test lah. Yeah. Transfusion is not a first line management for IHA. So you should only think about it if the patient is decompensated lah. Yeah. I mean, for her lungs is not good lah. So you probably can give excuse to transfuse at a lower threshold. Yeah. But for patients who have no lung issues, we usually kind of don't transfuse patient as a first line. Like we won't transfuse patient at the word go lah. Yeah. She was jaundice already, isn't it, when she came?
Yes.
So if she was jaundice already, then with anemia, of course, you think about hemolytic anemia. Unless the patient is deep jaundice, like deep jaundice could be a liver problem now. If the patient is mildly icteric or just mild jaundice, yeah, with anemia, then you think about hemolytic anemia. So you would do the Coombs test. But this Coombs test, there's something there, isn't it? There's IgG positive, C3d positive. IgG is usually we refer it to as the warm antibodies, and C3d is the complements usually signify cold antibody. But this patient also, they mentioned something about anti-S, isn't it? Anti-big S.
Yes.
So that's the problem with, I'm not sure, was she transfused when she was in Pitas?
She was given 1 pint of Paxil in Pita.
Yeah. So the problem with this patient is this, you see, she is already highly, her immunity against the red cell antigen is already highly alerted, highly active. So that means when you give the red cell to her, she can develop other antibody against a specific, the antigen that she doesn't have lah. So in this case, apart from the auto antibody that she has, she also have an allo antibody, which is the anti-big S. Yeah, that probably resulting from she got the blood, when she got the blood in Pitta, somebody gave her the blood in Pitta, she developed antibody against it lah. So that's something to be alert of lah. That's why we don't really like to give blood to this patient. So usually the trash, so I mean the thing is, you didn't show me the cross match lah. Usually for this patient, the cross match might be not compatible lah. Or least incompatible. They will provide you the least incompatible blood usually. So that's for the hemolytic anemia. So for us is we will transfuse. I mean, my teacher tell me this is just a rough one, no scientific kind of backup, but it's like if the person is 40 years old probably the patient can tolerate until 4 if there's no underlying heart or lung problem, you know. Yeah. So we have patients who are 3 point something that we you know, we just keep and watch. Yeah, if the patient is well, no lung issue lah. Of course, COVID got lung issue, so you probably want to transfuse the patient at a higher threshold. Yeah, a lower threshold. Sorry. Yeah. Regarding the COVID thing, so far ITP is more related to like infection, especially in children. So if the child got infection, they might get ITP, and after a while, you know, even without steroid treatment, the child recovers. You know, they have been is common for children when they have the ITP. For IHA, most of the time we have to treat with steroids. So whether these patients has this is like the starting of a IHA, because IHA tends to be chronic. So patients, I mean, they are steroid responder and steroid non-responder. So she's a steroid responder. And quite commonly, at least half the patient, they relapse. Yeah, they relapse later. Yeah, so that's the time when they relapse or they're refractory to steroid. That's the time that we think about rituximab for them. Yeah. So whether I don't know what's the latest HP.
On the 27th December, the HB was 13.3.
So that's like normalized now. Normalized. So I mean, we just watch her. How much prednisolone is she on now?
This one I just asked the doctor lah. She's the doctor is a MA, so she said she just on 0.75 milligram per kg of steroids lah.
Cannot be lah. So much 0.75.
That's why I also asking, but they said they have been tapering down.
She's in Pitas, is it? Now she's in Pitas.
She's following up in Kudat.
In where? Sorry.
Kudat Hospital.
Oh, Kudat. Okay, we'll see onto that lah. I think it should. I mean, it's already 2-3 months,
Yeah.
Yeah, it should be cut down to quite lowish dose lah. Should be 0.75 lah. But anyway, I mean, it's like if after we cut down off the steroids, if the disease, usually the typical IHA case, we will cut down slowly lah. But what happened is the higher dose we cut down faster, but we'll keep like maybe 20 milligram, 15 milligram for a longer period. So maybe cut down slowly and keep 5 milligram for a very long time lah. But for her case, if it's related to COVID, we probably will cut down off fast, maybe a bit faster lah. Because the usual non-infection related IHA, the one that tends to be chronic and they relapse quite easily. G6PD is something different lah. G6PD, you see, the IHA is mostly extravascular hemolysis. That means the urine is usually not dark color. Yeah. Whereas G6PD is an intravascular. G6PD is not an immune problem. It's an enzyme problem, enzymopathy. So the urine usually dark. They have hemoglobinuria. Yeah, they can get renal failure that because of the hemoglobinuria. Yeah. So the one actually the treatment is supportive, which is transfusion, hydration, folate, things like that, and then the situation will improve lah. So it's a different thing like intravascular. The LDH tends to be higher, whereas IHA tends to be extravascular. That means the antibody trigger the ingestion of the antibody tagged red cell by the spleen, like that, or the spleen or the macrophages. Okay, any question?